The Fox and the Goat. One day, a fox fell into a deep well and could find no means of escape. A goat, overcome with thirst, came to the same well, and seeing the fox, inquired if the water was good. Concealing his sad plight under a merry guise, the fox indulged in a lavish praise of the water, saying it was excellent beyond measure and encouraging him to descend. The goat, mindful only of his thirst, thoughtlessly jumped down. But as he drank, the fox informed him of the difficulty they were both in and suggested a scheme for their common escape. "If," said he, "you will place your forefeet upon the wall and bend your head, I will run up your back and escape, and will help you out afterwards." The goat readily assented, and the fox leaped upon his back. Steadying himself with the goat's horns, he safely reached the mouth of the well and made off as fast as he could. When the goat upbraided him for breaking his promise, he turned around and cried out, "You foolish old fellow! If you had as many brains in your head as you have hairs in your beard, you would have never gone down before you had inspected the way up, nor have exposed yourself to the dangers from which you had no means of escape." The moral that Aesop sends us across time: look before you leap.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. When we see a critical value or we're in a situation where we must act, it's so easy to overreact. This is true for many things we encounter in emergency medicine, but pediatric dysrhythmias, I think, offer a good example of this. Almost always do we have a second, a few seconds, half a minute to look at the patient as a whole, come up with a differential diagnosis, and then treat worse first. Today, we'll talk about the recognition and management of cardiac dysrhythmias in children and when to look and when to leap. Of course, we know that dysrhythmias in children, including cardiac arrest, are most often not from a primary cardiac cause. Any cardiac instability, tachycardia or bradycardia, think first respiratory. But you knew that. And you're already applying oxygen, blow-by, mask, high-flow nasal cannula, maybe even BiPAP, or now you're bag valve mask ventilating. Maybe you've already gone there. Intubated, giving the child all you got in terms of oxygenation and ventilation, and yet still too fast, too slow, or even a no-go. This is what we'll talk about today. Remember, the mantra here is prevention, early recognition, and rapid stabilization. First, is this a tortoise or a hare? Too slow or too fast? For pediatric bradycardia with a pulse, but poor perfusion, maybe that is altered mental status, poor capillary refill, or the ominous hypotension. Open the airway, assist breathing is needed, IV O2 monitor, our motto. And if that helps, great, you did it. Except it didn't help just now. If the heart rate continues below 60 beats per minute and you still have poor perfusion despite your actively bagging the child, perform CPR. I know this may seem aggressive if you think about how we treat adults. We really only start CPR if we have no pulse. In children, since they're dependent on heart rate for their cardiac output, if they are woefully inadequate at a heart rate of less than 60, then that really is an equivalent to cardiovascular collapse. Less than 60, symptomatic after trying and treating all of the things you can from a respiratory cause, CPR. After a round, if that doesn't help, add epinephrine 0.01 milligrams per kilogram of what concentration? What is it? Yes, 1 to 10,000. This is much more dilute than the 1 to 1,000 that you may use for down the ET tube. You're still giving a huge dose of epinephrine, so don't worry, but the cardiac epinephrine is always, what? 1 to 10,000. And that's it. You keep going down your algorithm, pulse check, rhythm check with minimal interruption of CPR. If you feel that there is an increased vagal tone, like when you stick a long piece of metal down the child's gullet during intubation, or perhaps a primary AV block, then you can add atropine at 0.02 milligrams per kilogram. If you get better, high five. Stop CPR and figure this out. If you go pulseless, start down the cardiac arrest algorithm. Now, we're going to stick to talking mostly about bradycardias and tachycardias, but since you asked, when you have a full arrest, no breathing, no pulse, first, is this a shockable rhythm? If yes, great. VTAC or VFib. Shock at 2 joules per kilo, and for subsequent shocks, 4 joules per kilo, to a max of 10 joules per kilo or the adult dose. Then you go for rounds of 2 minutes, continuing CPR, always looking for a shockable rhythm, and always adding something else to each round, be that epinephrine or amiodarone or lidocaine, and then epi, and then you continue. For asystole or PEA, it's good quality CPR, good rescue breaths, and rounds of epi, always trying to figure out why this is happening. No, not why this is happening to you when all you wanted to do was go to the bathroom, but what the underlying pathophysiology is. Hypovolemia, hypoxia, hydrogen excess, so acidosis, hypoglycemia, hypo or hyperkalemia, hypothermia, or tension pneumothorax, tamponade, toxins, or thrombosis. The whole point of treating asystole or PEA is, first, getting them into a shockable rhythm, and second, figuring out how to prevent or treat what got you there. Now, I know you know all of this. It's kind of comforting in cardiac arrest that you can't make them worse. You can only make them better. So follow the algorithms to free up your brain to think. What we'll talk about now for the rest of today is actually a little scarier. It's the child at risk for decompensation, when you can definitely do harm. Let's go over some cases where we find out how slow can you go. Shake things up. Shanae is a 4-month-old baby girl with a history of maybe seizure disorder. She's brought in by her mother for another of what she calls a fit. This has been happening for the past 2 weeks. She was recently admitted for a presumed seizure, and her workup was all negative. She even had an extensive non-accidental trauma workup. It's all negative. The child goes home. Coming in now, the child is irritable, but she seems to have good perfusion. You see a pulse on the monitor of 66 beats per minute. It's sinus, and there is a P wave for every QRS complex and vice versa, but with substantial pauses, seemingly at random. In front of you, her heart rate speeds up to 130s, then down to the 70s. She's semi-stable now, so you have some time to investigate. Pacer pads on, IV access, point of care electrolytes. You really dig into the history with the mother. The child was born via normal spontaneous vaginal delivery. All was well, except it was a home birth, and she only had 1 prenatal visit. So not much to go from the child's perspective, so let's get more of a maternal history. Mom seems to be a bit healthcare avoidant, and you get a sense that she's had some bad experiences in the past. Also, she's had a lifelong history when you talk to her of always having joint aches and fatigue. She's been treated for various things. She goes to the emergency department here and there for some lung problems, some liver problems, and all she can say for certain is that she has low blood. What is going on here? The child has a slow and then a fast heart rate, pretty consistently. Some may even call that tachybrady syndrome or sick sinus syndrome in a newborn or young infant whose mother likely has untreated lupus. Neonatal SLE. About 1% of babies born to mothers with lupus will have positive maternal antibodies. There is some cross-reactivity with the tissue in the SA or AV nodes, and babies can present with congenital heart block. The diagnosis is usually made at birth or within the first few months of life. IVIG can be given during pregnancy as prophylaxis to mothers who are at risk. When the babies are born, the majority of them will need pacemakers. Sick sinus syndrome may be intrinsic or extrinsic. Intrinsic sinus node dysfunction may come from a collagen vascular disease, like in this case, or postoperative congenital heart disease or myocarditis. Extrinsic sinus node dysfunction may be caused by an overdose in cardiac drugs, any electrolyte disturbance, thyroid dysfunction, or even in severe sepsis. So, you stabilize, you call cards, and you can optimize her. Now, we can't fix her underlying problem, but we can definitely look for things that would tick her SA and AV nodes off, and we can replete volume, we can replete electrolytes as needed. Management will include observation, medications, both for tachycardia and bradycardia. It's kind of odd because they're often on both of those meds, kind of like fixing the boundaries of the heart rate. And of course, pacemaker insertion. If you have a patient who has persistent bradycardia, after optimization of oxygenation and ventilation, you may try atropine for increased vagal tone or a possible AV block, or just go to transcutaneous pacing. You'll need the pediatric pads for children under 15 kilograms. The negative electrode is over the mid-sternum, and the positive electrode on the back between the scapulae. You can also alternatively place the positive electrode on the right anterior chest, just under the clavicle, and the negative electrode on the left side of the chest, over the fourth intercostal space, mid-axillary line. Remember, the smaller the pad used, the more output energy may be needed, so you adjust as you need to sense and capture. That will be different for every patient based on age and weight and habitus. For children over 15 kilograms, use the adult pads. Just be sure that the pads don't touch each other. The goal of transcutaneous pacing is to depolarize the myocardium in the ventricles, because that's where the money is. We're not trying to pace the atria. It's a brute force technique to zap the ventricular myocardium into submission with an overwhelming external force. Because of that, we have to be careful to use just enough energy to capture the ventricles, but not too much energy to damage them. Now, there are two factors that determine capture: the output energy and the time over which the energy is delivered, called the pulse width. The longer the pulse width, the less energy is needed to overtake the myocardium. Luckily, the pulse width, which is the time over which the selected energy is delivered, is built into the machine. It typically ranges from 20 to 40 milliseconds. What we have to do is select the energy output in milliamps and the frequency in beats per minute. So, you place the pads. You connect your ECG leads to the machine. The rate is easy. Just select the age-appropriate heart rate. For Shanae, she's 4 months old, so a regular rate would be 120 beats per minute, for example. Okay, now we select the output. Remember, the whole point of synchronizing to the QRS complex is to avoid blindly pacing, where an electrical impulse hits the myocardium when it's trying to depolarize. We don't want that Q on T phenomenon, which can deteriorate quickly into ventricular fibrillation. So we synchronize pace. The machine senses the QRS complex. We increase the energy to capture the ventricles, and the machine knows to give that impulse right at the QRS complex. It's wide because the heart's depolarization is not down the usual conduction system. It's external and takes slightly longer than your native impulse. For an adult, to keep it simple, I start at 100 milliamps as an output and a rate of 100 beats per minute, and quickly bring down the output energy until I lose capture. Then I add about 10% to that, get capture again, and monitor. In children, a good rule of thumb is to start at an output of 20 milliamps. You start pacing. You increase the output until you see that after every pacing spike, you achieve a wide QRS complex. You titrate the capture and use just enough. Shanae is started at a rate of 120 beats per minute, and you start the output at 20 milliamps. You see the spikes at appropriate times just before the QRS, but it's not capturing completely consistently. So you increase it to 30 milliamps. Better, but still not completely consistent. You are looking for that threshold energy level that consistently captures each QRS complex. You're checking her pulse. Is that her real heart rate? No, not yet. Aha! 35 milliamps does it. At that point, you know that the minimum threshold for output is 35 milliamps. So now you need to add a buffer. Add 10 milliamps to whatever threshold you find. In this case, this sets her at 45 milliamps at a rate of 120. Her perfusion is now looking better. Her blood pressure is fine. You are synchronized pacing her transcutaneously. Excellent. Now, this is only a bridge. If she truly needs this ongoing, then she'll likely need transvenous pacing. I would not recommend trying to start this downstairs for many reasons. You can get her to an OR or an IR suite with good anesthesia, and that's probably for the best. In the meantime, though, transcutaneous pacing is painful since all of your muscle will be contracting, not just your heart, but your pectoralis muscles and others. It's painful and distressing. Make sure you give some good fentanyl and watch that airway. Hurry up and wait. Jason is a 9-year-old boy brought in by his mother for feeling dizzy today. He has episodes of nausea and vomiting, some diarrhea yesterday and today. His mother explains that he had this 2 months ago and they did a bunch of tests and they found that the big pipe from the heart is kinked. It's hard to get them to remember actual diagnoses or medical terms, but you think you're getting somewhere with this now. Apparently, Jason is terrified of having surgery. He's been surreptitiously taking just a little bit more medicine each time, sneaking it from his mother. He thought that if he takes his medicine, he won't need surgery. On arrival, he appears well, but tired. You go to listen to his heart and lungs, and it is striking how slow it is. This is not the normal chest auscultation of a 9-year-old. You think his pulse is about 40 beats per minute, but he has good perfusion, he's awake, he's alert, he's talking to you, his blood pressure is okay for now. You put him on the monitor and find a regular rhythm, very slow, and where the P's at? You see a relatively normal QRS, but at 40 beats per minute with no P waves. It's a junctional escape rhythm. Here, either the sinus node is dysfunctional, so no signal is being transmitted, or the AV node is blocked, no signal is received. The rest of the conduction system looks up at the SA node, looks over to the AV, and says, "Hey, what do you want me to do over here?" And so just at the AV junction, the myocytes there set the pace because it's really an emergency backup and no one else is there to set the pace. Junctional escape rhythms are also called nodal rhythms. They can be benign. They can be seen in older children or adults in normal sleep. But in an awake patient in the ED, we think inflammatory, AV blockade, or post-op. A classic inflammatory cause is acute rheumatic fever. Any AV blocker like a beta blocker or calcium channel blocker can also do this. In Jason's case, taking too much of his digoxin is a double whammy. Digoxin has effects on both the SA and AV nodes, even though the target pharmacodynamics are on the AV node. He'll need some digibine for what appears to be digoxin toxicity. In general, for junctional rhythms, not due to a toxin, asymptomatic patients do relatively well. Patients who are symptomatic with their escape rhythm need to be stabilized, admitted, and they need a huge workup, including electrophysiology studies. Some patients just have idiopathic causes, so an antiarrhythmic may be needed. Interestingly, phenytoin used to be used more widely as an antiarrhythmic before it was an antiepileptic. It's a 1B antiarrhythmic, so it works on sodium channels and can be used for ventricular arrhythmias, but it has a very narrow window of indications, and I mention it only as something to discuss with your friendly neighborhood cardiologist. Bradycardia is pretty obvious when you see it, but we may be a little late to the party in recognizing non-sinus tachycardia. Why? Because an elevated heart rate is where we live in the PEDS-ED. Crying, fever, upset, pain, all of those things make tachycardia per se pretty common, but we need to be vigilant that it is actually sinus tachycardia and not a non-sinus tachycardia. Let's go over some cases. He just slumped over. Loto is a 15-year-old boy who's been feeling ill for the past several days. His brother brings him in and mentions that Loto has had some fever, headache, and diarrhea. He had seen his primary care physician earlier that day and was given the panacea, amoxicillin. When Loto became altered this afternoon, he arrives with his older brother. His temperature is 38.1, heart rate 147, blood pressure 70/40, respiratory rate 22, 98% on non-rebreather mask. His GCS is 124, and his exam is otherwise non-contributory. There's no evidence of infection. There's no trauma. There's really no other clues for you. So, IV O2 monitor. On the monitor, you see a regular, narrow complex tachycardia. It's 147, 147, 147. There's no beat-to-beat variability. At first you think maybe this is just SVT, but something doesn't match. You're about to give adenosine when luckily the EKG tech is right there. There are P waves. So, not a junctional rhythm because there are P waves. It's not sinus tachycardia because there's no beat-to-beat variability. It's not your grab bag SVT because you see P waves. What gives you a narrow complex tachycardia with P waves, but without any obvious input from the SA node? Well, it is an SVT, but it's not at the AV node. It's a rogue cluster of myocytes in the atria, giving you P waves, but without any input from the SA node. This is atrial tachycardia, often with rapid onset and rates that can range from 120 to 300 beats per minute, so it can be misinterpreted as sinus tachycardia. Luckily, often atrial tachycardia will present above 200 beats per minute. In Lodo's case, he was on the lower side. Causes of atrial tachycardia are anything that can irritate the myocardium, so viral infections, especially mycoplasma, myocarditis, sepsis, and other toxins. What do? We treat simultaneously for sinus tachycardia because, well, we just don't want to be too smart for ourselves. Look before you leap, right? You may end up trying adenosine, and if you're unsure if this is generic SVT, so usually a narrow complex tachycardia without P waves, that grab bag diagnosis, that's fine. In this case, Lodo needs DC cardioversion, and now. He's altered and has hypotension. These are two separate indications for cardioversion. You attempt cardioversion twice. You add procainamide. Now that with a third cardioversion attempt, and he is back in sinus rhythm at 110 to 117 beats per minute. You treat for presumed sepsis, and later on he does well. Atrial tachycardia is hard. It's almost always misinterpreted as sinus tachycardia, and frankly, sometimes we're too eager and we can think that it's atrial tachycardia when it's just a gnarly sinus tachycardia. Like anything in EM, we assess, we make an intervention, and we reassess. Keep it on your differential, and just know how it's hard to get someone out of atrial tachycardia. They may be in it for hours or even for days. Medical management is usually the way to go, but if you're hemodynamically unstable, we gotta electrical cardiovert you. Otherwise, if all is well, IV medications work well. More on that in a moment. Hop, skip, and... Macey is an 11-year-old girl who's brought in by her school's principal because she felt nauseated and dizzy at school, and the way she looked worried them. Her symptoms began while jumping rope with the other girls. Macey doesn't know much about her medical history other than she has hold your arm. Hold your arm. Mom is unavailable, but the principal will keep trying to reach her. She's afebrile, her heart rate is 120, so that seems okay for an 11-year-old. Her blood pressure is 112/70, respiratory rate is 22, she's 98% on room air. No signs of trauma. She does have some limb anomalies, and maybe that's where she was going with this. Before you can pull all this together in your mind, she grabs your arm and feels dizzy again. On the monitor, she has an irregular, narrow complex tachycardia. You get an IV in her, and the lead strip shows some sawtooth P waves. She has atrial flutter. But why? What did she say she had? Hold your arm? Wait, atrial flutter, limb anomalies. She has Holt-Oram syndrome, also called heart-hand syndrome, associated with an atrial septal defect. They can suffer from multiple atrial arrhythmias, including this one. Atrial activity can be anywhere from 240 to 400 beats per minute, caused by a reentrant circuit confined to the right atrium. It can be regular or irregular and is characterized with a sawtooth P wave that we saw on Macey's rhythm strip. So the atrial rates are very high, and the AV node tries to block what it can, except when it can't keep up. Often we'll see a 4-to-1 block or a 2-to-1 block. In a 4-to-1 block, the atrial rate may be as high as, say, 360 beats per minute, but the ventricular rate is only 90. The AV node is blocking 3 out of 4 atrial impulses here. In 2-to-1 block, the atrial rate may be going at, say, 320 beats per minute, and you end up with a ventricular rate of 160 beats per minute, for example. Atrial flutter in children is almost always caused by structural heart disease. In this case, Holt or Rom syndrome. It's a common post-op finding also in children with congenital heart disease after a Fontan, say for hypoplastic left heart syndrome, or in the Mustard procedure, an atrial baffle, or the Senning procedure in an atrial switch. Both of these are used in the surgical treatment of transposition of the great arteries, something that's done at birth. The goal here is to control the rate, which we can do with our little friend diltiazem at 0.25 mg per kg IV over 2 minutes. You can then start a drip at 0.1 mg per kg per hour if you need to. Other meds for atrial flutter include procainamide or amiodarone, but as always, if unstable, DC cardioversion is always an option. Amiodarone is a lipid-soluble antiarrhythmic that works on multiple channels. It's a non-competitive inhibitor of alpha and beta adrenergic receptors, so it causes a potent sympathetic block. The upside is that you have AV nodal suppression. The downside is that you can have profound vasodilation as well. But by its effect on potassium receptors, it can prolong the QT, which may help in prolonging repolarization, so that's going to be a plus in a tachydysrhythmia. But too much QT prolongation, of course, can cause something like, say, polymorphic VTAC, torsade de pointe. Amiodarone also inhibits sodium channels, slowing conduction in the ventricular myocardium, which is a plus, but it can also prolong the QRS, which is a big minus. Put all of that together, and it's been shown that its effect is really rate-related. It works best in faster heart rates, which is why we use amiodarone for SVT or for VTAC. Procainamide is a sodium channel blocker that prolongs the refractory period and depresses the conduction velocity within the conduction system. However, it has a paradoxical effect in that it shortens the effective refractory period of the AV node and increases AV nodal conduction. This can cause an increased heart rate when used to treat ectopic atrial tachycardia. Procainamide is best used for atrial fibrillation, for flutter, and SVT, and as we remember, it is the drug of choice for WPW. Of course, procainamide will prolong the QT as well, so it shouldn't be used together with another drug that prolongs the QT, like amiodarone. Remember, you have to choose between them. There can be only one. Atrial flutter may deteriorate into atrial fibrillation, and again, this is uncommon in children without some cardiac structural defect. Having said that, teens somehow can get into trouble with alcohol, as we know, or maybe someone with a thyroid disorder may come in with atrial fibrillation with a rapid ventricular response. Weebles periodically wobble. Tommy is a 5-year-old boy who was brought in by his family for falling down on the playground. Apparently, everyone is very upset about this. Tommy looks very well. He has a mild abrasion on his knee. He's 5 years old. You're unsure what role you're going to play in his care here, but the parents are very anxious. They're upset because he always falls down when he runs. You try to get a sense of why today is different. It's not. Again, you kind of feel yourself semi-tuning out here. You steady yourself. Wait a minute. Let's listen. There is just enough weird nervous energy in the air to clue you in that these are not just helicopter parents. This is something very wrong until proven otherwise. Okay, let's get some vitals. He's afebrile and his heart rate is 190? He's pretty chill for a heart rate of 190. You were not expecting that. The rest of the vitals are normal. Tachycardia without any reason. Okay, let's look at his EKG. It's fast. It's narrow complex. No P waves. Aha, that's an SVT. If only it were that easy. Supraventricular tachycardia is, as we mentioned, a grab bag for a long list of possible diagnoses. They are all reentrant tachycardias, but they vary on where and how. In children, the most common SVT is AVRT, atrioventricular reciprocating tachycardia, AVRT. It is through an accessory pathway. In adults, the most common SVT is AVNRT, atrioventricular nodal reentrant tachycardia, AVNRT. This happens within the node itself. So, children, accessory pathway, AVRT. Adults, within the node itself, AVNRT. Just remember that adults have more problems, they get more letters. AVNRT for adults, AVRT for kids. Good. AVRT, atrioventricular reciprocating tachycardia via an accessory pathway. The most common cause is going to be Wolff-Parkinson-White syndrome. If you know this is WPW, you should treat it with procainamide, the drug of choice. You give 5 milligrams per kilogram up to 100 milligrams over 5 to 10 minutes. You can repeat that every 5 to 10 minutes until you've reached either 17 milligrams per kilogram max loading dose, or you have suppressed the AVRT, or you start to get hypotension, or you've increased your QRS complex by more than 50%. Of course, if the child is unstable, then electricity is always your friend. In this case, we would use synchronized cardioversion. There is a less common presentation of WPW in which you can see a wide complex tachycardia. Treat that like any other wide complex tachycardia, like it's VTAC until proven otherwise. WPW with atrial fibrillation will look bizarre, and irregular wide complex tachycardia. It looks terrible, but often the EKG looks much worse than the patient. Take a moment to get a history and choose your options. One important piece of information to hold on to when we're thinking about SVTs is, in my opinion, to delete verapamil from your formulary for infants and small children altogether. When an infant or young child receives verapamil, they can develop refractory hypotension. It poisons their receptors, and they're at risk for spontaneous cardiac arrest. You can technically use it in older children, but we have safer drugs like procainamide. It's really a great go-to in SVT if you're not using amiodarone or adenosine. So choose either procainamide or amiodarone, not both, and throw verapamil away. She don't lie, she don't lie, she don't lie. Megan is a 13-year-old girl who snuck out of her house to go to a party for her older sister's friend. She tries cocaine for the first time, and surprise, surprise, she has chest pain and shortness of breath. She can't stop talking about it, and she can't stop talking about what Sarah said to Michelle, and OMG, she can't even with her. The nurses' eyes are almost glued to the back of their heads from the extreme eye roll. But we're here to do our job, and worst first, right? You get her on the monitor, and her heart rate is 117 beats per minute. It's sinus. But you see a few wide complexes that are mixed in there. 3 or 4 or 5 at a time. She has runs of ventricular tachycardia. VTAC is a wide complex tachycardia originating from the ventricles, typically greater than 120 beats per minute, and the QRS is typically greater than 140 milliseconds. There is AV dissociation, and as we know, this can lead to rapid deterioration. Now, in general, and not in Megan's case, for stable VTAC, you can use amiodarone or lidocaine and synchronize cardiovert if the patient deteriorates. For unstable VTAC, so VTAC with a pulse, you go straight to synchronized cardioversion at 0.5 to 1 joules per kilo, and you can escalate to 2 joules per kilo. For pulseless VTAC, you treat it like ventricular fibrillation, so there's no synchronization. You defibrillate at 2 joules per kilo, up to 4, and finally up to 10, like we mentioned before. In Megan's case, there's no structural heart disease. She's poisoned by a sympathomimetic, so in cocaine-induced VTAC, you use sodium bicarb, not as an alkalizing agent, but as a source of sodium. It's a bolus. You give 1 milliequivalent per kilogram. Cocaine is a fast sodium channel inhibitor, so that means that it's voltage dependent. Sodium channel blockade prolongs the action potential propagation and so prolongs the QRS duration, and that impairs myocardial contractility. Give more sodium via sodium bicarbonate to override cocaine's sodium channel blockade. You can also use lidocaine, 1 milligram per kilogram. Lidocaine is a tried and true pure sodium channel blocker. It decreases automaticity, and therefore it can suppress ventricular arrhythmias. Lidocaine may cause myocardial and circulatory depression and possible central nervous system symptoms like drowsiness, like disorientation, muscle twitching, or even seizures. What meds do you want to avoid in cocaine use? That's right, no beta blockers if they're intoxicated. You will channel all of the sympathomimetic activity to alpha activity and cause hypertension and ischemia. Pro tip, you can also chill Megan out with some benzodiazepines. Charlie is a 7-year-old boy who was playing in his Little League baseball game when the baseball struck him directly in the chest. He's unresponsive. There's no bystander involvement. He's brought in by ambulance, pulseless, apneic. BVM, CPR are in progress. On the monitor, you see disorganized rhythm, ventricular fibrillation, commotio cordis. It's an erratic rhythm that results in inadequate contractions. Mortality depends on time to resuscitation and bystander involvement. Various EMS agencies report anywhere from 4% to 33% return of spontaneous circulation, but even those with return of spontaneous circulation, less than 10% survive to hospital discharge, and only 1/3 have a good neurologic outcome. In this case, follow the cardiac arrest algorithm. In summary, always optimize the respiratory status. Without that, nothing else you do will be helpful. Use the EKG to think anatomically, then physiologically. Be ready for life-threatening complications, but if you have a moment, think through what is happening and what you need to do now or potentially later. Look before you leap. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.